Hello everyone, I'm Leslie Cornwell, Certified Nurse Midwife with Empowering Midwifery Education. This section has to do with recommended routine screenings during pregnancy. A legal disclaimer we put at the beginning of all of our presentations. This information is for general and educational use only, not intended to substitute for professional, legal, or clinical advice. We strive to keep our information as accurate and timely as possible, but make no promises and guarantees it works for your local unique situation. Course objectives is students will be able to verbalize what exactly are prenatal screening tests. They'll be able to talk why they're important to understand as midwives, healthcare providers, and be able to adequately educate our clients we're taking care of on their best possible options. They'll be able to verbalize the recommended screenings based on their trimesters, risk factors, and assessments that make you get more information. The information is really important because as midwives, healthcare professionals, we take care of clients, patients, babies during pregnancy, and there's a lot of things that can happen. Most of the time birth is normal and healthy, but part of what makes it normal and healthy is some routine screening, some things to confirm that there's low risk, healthy risk factors aren't present. So each and every visit, from the very first visit to postpartum visits, there's specific screenings and recommendations to be done to help reinforce that this is a low risk, healthy candidate for a mom and a baby to be born at home, at a birth center, in the hospital, independently with a midwife, needing to collaborate with a physician. The screenings are what makes the outcomes really, really high, and you know when you need to add additional resources and assessments and further testing based on those recommended guidelines. So let's go to the basics. What are prenatal screens? So a prenatal screen is just a generalized word meaning these are recommended standards with ACOG, ACNM, MANA, locally, nationally, internationally recommended to be offered throughout the pregnancy to help reinforce screening. So there's certain things we're going to talk about with the prenatal panels, the 20-week anatomy scan, the diabetes screening, their RH status and compatibility. There's a lot of extra things that are recommended to watch for that will help to increase decision making for the mom and the family of what birth setting, what practitioner, what style of birth outcome, and the interventions that may be needed based on those findings. Some of the screenings to think about are the first prenatal screenings. An ultrasound is sometimes recommended to be done first trimester if they don't have a good accurate period, they don't know their cycles, their last known menstrual cycle. There's a lot of different reasons, and the data shows if you get an ultrasound done in that first trimester, especially around 5 to 7 weeks, it's good within 3 to 5 days of the estimated due date. So it's pretty standard in the medical world to do dating ultrasounds to add as dating criteria on top of her last menstrual period. But in the midwife world, we typically will order a first trimester dating ultrasound if we don't have a good accurate date to go from. Later on in the pregnancy, you're going to do dating, you're going to check fluid levels, you're going to really do further testing. But in the beginning, some people may want some genetic testing done for the nuchal translucency and the Down syndrome risk depending on age and different things. So it just depends on your patient's unique situation. You could do some early blood tests for genetics, essentially sequential screenings, the prenatal panels, HCG hormones if she's having some spotting. You can do serial HCGs every 48 to 72 hours. That HCG hormone should be doubling up to 9 weeks gestation for normal, healthy, viable pregnancies. You can order ultrasounds if she has right lower quadrant pain, right or left quadrant plane, worried about ectopic pregnancy to confirm that there's a viable baby in the uterus versus the fallopian tubes. So there's different things you can do for just checking on the mom and the baby. Prenatal panels, the blood type, rubella, hepatitis B, hepatitis C, syphilis, HIV, iron levels, so CBC. There's so many different things that you can order. Her blood type, her RH factors. If she is RH positive, it doesn't matter if the baby is RH negative or positive. If the mother is RH positive, we'll have a thorough discussion of giving her RhoGAM during the 28-week gestation and then checking the baby's blood type postpartum. If we know now 110% positive that the dad is Rh negative as well as the mom is Rh negative, then the baby is going to be Rh negative. The concern is that baby inside of mom could be Rh positive, and it can have Rh incompatibility and concerns with future babies, miscarriages, pregnancies. So that's why the RhoGAM is recommended at 28 weeks and checking the baby's blood type postpartum. There's chorionic villi sampling. This is more maternal fetal medicine, higher invasive, higher risk things. There's other things you do and recommend before that are less invasive if you're trying to do DNA genetics. There's the difference between screening tools and diagnostic tools. The screening tools are more of risk factors and probabilities, like genetic testing is more of a ratio, versus these more invasive procedures are more diagnostic ones and more getting the sample of the genetics, the DNA itself. So you can do the chorionic villi sampling. It's done between 10 to 12 weeks, particularly those moms that are considering an abortion, are really wanting to know genetic abnormalities, specific conditions like cystic fibrosis. They will typically do it through transabdominal, and then the testing can be done also transcervical, just depends on the different types and the side effects and what you're looking for. There's additional testings to do with second trimester, so from 12, 13 weeks all the way to 28 weeks. 20-week anatomy scan is a pretty common thing that's recommended. It can be between 18 to 22 weeks. If you wait a little bit longer, they have a less issue checking certain parts of the baby, the heart valves, certain things that may be harder to see. Some insurances will pay for a repeat ultrasound if you do it at 18, 20 weeks and they weren't able to see all the anatomy. Sometimes they aren't. As the baby gets 28 weeks on, it's just harder to see some of the minute details of anatomy. There's certain blood tests that you can do in the second trimester for genetics that are a little bit later versus earlier. The quad marker screening for neural tube defects can be done at this time. There's other things to just think about. Most of it with the second trimester is going to be genetic testing, 20-week anatomy scan. 28-week is right on the cusp of second, third trimester, doing the glucose testing, the Rh compatibility, the prenatal panel, depending on when they enter pregnancy care. If they're a new OB is at 18 weeks, some of these first trimester recommendations are going to merge with your second and third trimester recommendations. The glucose tolerance testing, there's different ways to do this. You can do a 1-hour glucose testing, you can do a 2-hour, a 3-hour, you could do some home monitoring for a couple weeks and rechecking a little later in the pregnancy. There's a lot of guidelines and recommendations out there. There's not a lot of data with the jelly beans and these other ways, or just not screening at all. Gestational diabetes isn't going to have any real obvious signs and symptoms until it's more severe, and so some of these screenings we do, like the blood pressures and the diabetes screening, the only way you can really know if it's present is the information you're gathering versus asking her questions of an assessment. So those are really important things to consider. Some people, based on risk factors, can do the glucose tolerance testing with their prenatal panel if they've had a large baby, diabetes in the past, obese, older, risk factors. You may consider doing an A1C in the first trimester, doing the glucose tolerance testing in the first trimester, but then also repeating it around 28 weeks. And sometimes I've even seen it where they're right on the borderline, or they're having symptoms, they're dipping glucose in their urine. Even after you do the 28-week gestation, sometimes that'll get repeated just depending on risk factors. There's other things that can be done, and amniocentesis can be done if you're worried about, these are more higher risk things that doctors would do. They want to actually get this fetal cells, maybe it's for genetics. It could be, I've seen it where they're considering doing an earlier C-section based on she's had a classical incision and there's a lot of risk factors and they want to deliver the baby closer to 35, 36 weeks. They'll get the lung maturity and they'll do some other different things with an amnio. So there's different screenings out there. Some of the ones the midwives will do and some of them that'll be high risk specialists, just depending. But I think the important thing is just to know what resources are out there, and even if you're not the one directly doing a specific genetic testing invasive procedure, you can help better prepare your clients what are exactly the different screenings and things that could consider. Third trimester screening, so that would be 28 weeks gestation on, and so it just makes a difference when they enter your care. When they start prenatal care, some of these screenings may be condensed together. You may not be able to do them anymore. So a more common one between 35 and 37 weeks gestation is the GBS, the group beta strep culture. It's a vaginal anal rectal swab that you will do to just see if that colonization is present during the last month of pregnancy. 80% of women it's negative, not present. 20% of women it just happens to be colonized during the end of pregnancy. It doesn't hurt her partner, but it is something that has a slightly increased risk chance of a very serious lung infection for the babies. And so that's part of our job as a midwife, is to talk about, even if our client doesn't want certain screenings and standards and testing, you look at risk factors, you make sure there's good informed consent. Depending on which testing, some of these are state mandated for pregnancy, so you may have to have a written agreement in place. But the whole point is we want to keep our own biases out of it. We want to give them just CDC guidelines, evidence, the standards. Evidence-based birth has excellent resources on what are the standards, what are the prenatal care screening options, and how do you take care of the mom. So this GBS swab can be pretty minimal screening option. I always stress to my families, just go in the bathroom, do a little bit of a swab inside your vagina towards the rectum. It's more information for the pediatrician. If you choose to do antibiotics, here's your options, here's the data to support decreasing that risk, and then the families can make a decision. So you really want to think about the group beta strep, where it's at, what are the options. There's a lot of things out there you can do with balancing the flora beforehand with garlic and keeping her healthy and probiotics. The whole point is you want to have the mom and baby as healthy as possible. So even if the baby is exposed to any of these infections throughout pregnancy, birth, postpartum, that they're able to fight off the infections themselves. That's the whole point. So prenatal screenings, there's a lot of different things you can do. There's some post dates in screenings as well. You can definitely do some ultrasound testing. You could check fluid levels. You could do non-stress tests. It just depends on how much skills and what you have on your arsenal to work with. But definitely just understanding when is a screening implemented, why, how to interpret the results, and what to do about it. What is within the scope of a midwife? What needs to be collaborated with a doctor? What needs to be transferred to a doctor or a hospital? So there's a lot of things to think about with prenatal testing. The whole point of prenatal screenings is to find out what's routinely recommended, talk about with unbiased informed consent, what are the options, and then based on the information you're gathering from those screenings and testings, are they still a low risk candidate for a home birth, for a birth center? Do they need to be transferred to a hospital? Maybe they can still be with a midwife, but they need the additional hospital setting based on the anatomy scan and the baby's heart and the lungs and certain things that are risk factors that you need extra equipment and skills available at the birth time. So it really makes a difference. The point of this is, if you ignore things and then you say she's low risk healthy because I didn't get that information, that's not what makes our outcomes great. Our outcomes are great because we've screened them, we've followed standards, we've reinforced this is a low risk healthy woman versus we just didn't do the screening. So I think that's part of the conversations that are really important to have among all midwives.